As tradition, a little bit of a brief potted history. I never try to intend to summarize anyone's work in this sort of occasion. I figure that that's the job of the lecturer. But nevertheless, it's worth noting some of the background that have led Mamas to be here this evening. So he secured a place at Oxford University to study medicine in 1991 and was awarded a BA in Physiological Sciences in 1994, having been awarded the Martin Ronke Prize in Medicine. He deferred entry to the clinical school and undertook a DPhil funded by the British Heart Foundation, but then went back to finish his clinical training and graduated in 2000. Mamas undertook his house officer training in the Nuffield Department of Medicine at Oxford and undertook senior house officer training at Hammersmith Royal Brompton Hospitals in London and the Royal Salford Hospital, in that case between 2003 and 2004. In 2006, he was clinical lecturer in cardiology at the University of Manchester, and during that time, he spent a year's sabbatical at the Manchester Interdisciplinary Biocentre, learning systems biology and metabolomics, and began to work with the whole animal physiology group of Professor Ludwig Neizes, studying the mechanisms of diabetic heart disease. Mamas undertook his clinical training in cardiology at the Manchester Heart Centre, where he trained in heart failure and interventional cardiology, and was awarded a CCT in cardiology in January 2012. He was appointed to his current post as Professor of Cardiology, the University of Kiel, and Honorary Consultant Cardiologist at the Royal Stoke Hospital in June 2015. He's published over 170 peer-reviewed papers in the highest impact international cardiovascular journals, using big data in populations with cardiovascular disease. His work has consistently attracted editorials from international leaders in the field, and indeed since his appointment to Kiel in June 15, he has already published over 40 papers in that time. He's a member of the FAR Institute, which has an aim to deliver high-quality, cutting-edge research linking health data with other forms of research, and he is a member of the British Cardiovascular Interventional Society Steering Group and on the research executive of the National Institute of Cardiovascular Outcomes Research. Given that heart disease remains a major cause of morbidity and mortality in the UK, and indeed across the whole developed world, it's easy to appreciate the significance of Mamas' research. And I'm sure we're going to find that this evening, and it gives me great pleasure to invite Professor Mamas. Mamas, Professor of Cardiology at this university, to present his inaugural lecture, Making PCI Safer, Insights from Big Data.
So thank you, Vice-Chancellor, for your very gracious introduction, and thank you to friends, family and colleagues for attending this important event. Before starting, for those of you that don't know me, my name is Mamas Mamas. I'm a professor at Kiel University and I practice as an interventional cardiologist at the Royal Stoke Hospital. And I'm going to start my talk, first of all, by presenting a bit about myself. I think to understand anything about one's career, one has to understand about the person themselves. So I'm going to spend maybe 5-10 minutes discussing how I got here and thanking the colleagues that helped me get to this position. The remaining 40 minutes of my talk, I'm going to talk about how my group has used electronic healthcare records derived from patients. You know, all of you here will have electronic healthcare records, and how we've used this information to help inform practice nationally and hopefully make the sorts of procedures that we undertake in hospitals much safer. So where did it all start? Well, this was me in 1974. I was born in 1973 at St Mary's Hospital, and interestingly became a consultant at that trust 37 years after this photo was taken. And here I am sitting very patiently, no doubt waiting for the treat that the photographers had promised me. And this is probably the only photo or time in my life that you'll ever see me waiting patiently for anything. That's not in my nature. So moving forward, this is myself and my sister, Gabriella. I thought if I'm going to have some embarrassing photos shown, I'll also have embarrassing photos of my sister. So this is when I was aged 4. This is when my sister was aged 1. And here you can see that we're both very loving to each other. No doubt you can imagine as soon as the camera was switched off, I was probably busy trying to throttle her as most young boys do to their sisters. And this is a photo when I started infant school, so I was about age 5 here. So I went to a state comprehensive, Woods Lane School, and spent a number of years there. Now, I always decided that I wanted to be a doctor. I don't really know when I really made that decision final, but I think it was during a science lesson when I was 11. And the science teacher was going round asking people, what do you want to do when you want to grow up? And I said to her, I want to be a doctor. And she said to me, young man, if you want to be a doctor, you've got to be good at science. And you're not very good at science. I think you should think about doing something else. So that really solidified my intent to do medicine. So anyway, I got good O-levels, went up to sixth form, and again, during applications to universities, my head of sixth form asked me, which universities I'd like to consider applying to. So I thought, Oxford sounded like a good place to go to. So I said, well, I want to go to Oxford. And I remember he was saying to me, look, you're a very good student, but we've never had anyone from this school get into Oxford to do medicine. So, don't waste your application. Just apply to one of the other places because it's difficult enough as it is, and you only have 5 chances. So being the stubborn person that I am, I completely disregarded his advice and got into Oxford in 1991. So this is a picture of myself, the fresh face of youth in 1991. And I spent a total of 9 years in my career in Oxford, really great career time in Oxford, real intellectual challenges. And during my first 3 years where I did my preclinical training, one of the things that we had to do for 3 months was to do a research project. And I did this research project in the laboratory of Derek Terrar, looking at the influence of compounds on electrical activity in isolated heart cells, and really got quite interested in this. And not only did I spend the 3 months working in the laboratory, I then decided to spend the whole summer working with Derek. And this is one of the reasons I feel so passionately about medical students being exposed to research. And we've been very lucky at Keele. I've had some really good medical students pass through. So Rafael Contronias, who passed through my lab last year, he got an ACF at Oxford University. Adit Narayan, who was awarded the top prize for his research project and the Chesterfield Prize, and Chunwai Wong as well, who's currently working with our group. So really, this research project as a medical student really started me on my career in research. So this is my graduation photo when I was awarded my BA in Physiological Sciences. And then I applied to the British Heart Foundation, working in the laboratory of Derek Terrar to undertake my PhD, again, looking at substances derived from different types of cells and how they can influence cardiac contractility. So during my time as a medical student, this was my very first paper ever published, and this was actually in The Lancet. So 15 years later, and 180 papers later, I still haven't quite reached where my first paper was published. And it was looking at patients with spinal cord injury and a hypothesis that I'd had at that stage. And this has now entered clinical practice from a hypothesis from a medical student. Anyway, I did research with Derek for several years, both during my DPhil and after, during my clinical training. And we published a number of papers looking at actions of different second messenger systems at the single cell level, looking at changes in electrical currents and so forth. I then left research and completed my clinical training at Oxford, and then did house jobs in Oxford, and funnily enough, in Stoke as well. So I was here for 6 months, and I actually came here to get general surgical training. So at that stage, I wanted to be a cardiothoracic surgeon. And I worked with James Elder, one of the old professors here, Christine Hallmark Deakin as well. And it really put me off surgery. So I thought, right, I'm not going to do surgery. I'm going to do cardiology. So I switched plans then and decided to apply for cardiology. I went back to London at the Hammersmith and the Brompton, and then came back down again to the University of Manchester, working with one of my mentors, Professor Ludwig Mises. I was his clinical lecturer, and his laboratory had a great interest in looking at mechanisms of heart failure, and they used different animal models of heart failure, particularly mouse models. And one of my research interests at the time was looking at diabetic mice and how diabetic mice can go on and develop cardiac dysfunction. And I also remember that whilst I was applying for this post, I was still a very junior person, and one of the people here, Bernard Clark, at the time was the chair of the cardiology training committee. And so the people that I used to work for advised me to go and see Bernard. So I took my CV along, and it was only a 15-minute appointment. And, Bernard, very gracious, spent an hour with me and said, young man, your CV, you've not really written it very well. So completely redrafted my CV to make it suitable for an application. Anyway, I applied, I got the post. So thank you, Bernard. I'm very pleased that you could make it here as well. And then during this time, between 2006 and 2012, I trained in interventional cardiology. So my mentors, friends and colleagues trained me. So Doug Fraser, we did a lot of work together. Fazal Dabadi here. Here we were in Florida, I think it was. And the other photos of us during this trip involves Faz holding various alligators and things. So I thought it's probably just better to put this photo here. There's one of my other colleagues, Dr. L. Omar in India here, who was thinking that he was the Maharaja, and Bernard Clark as well, who also is here tonight. So anyway, I spent 6 very happy years in Manchester as a trainee, where I was trained in interventional cardiology, and was finally appointed as a colleague and as a senior lecturer, and spent 3 very happy years there again before arriving to Stoke to be Professor of Cardiology here. So I'm a consultant cardiologist, and my interest is cardiovascular disease. I hate to be morbid, but about 1 in 3 of us in this room will die from cardiovascular disease, so it is important. And coronary heart disease is probably the biggest single cause of death in the United Kingdom. So in 2012, about 1 in 6 of male deaths and 1 in 10 of female deaths were from coronary heart disease and heart attacks. And this accounts for about 74,000 deaths every year. So I'm an interventional cardiologist, and I do these procedures called cardiac catheterizations. And what they involve is looking at the coronary anatomy, so putting tubes through people's arteries under X-ray guidance and injecting contrast down the coronary arteries to see if there's any blockages or narrowings. And if we find blockages or narrowings, we can treat them. So this is an example of a procedure. So you can see the heart beating. The tube goes through the artery all the way round to the coronary artery. And then we inject dye down the coronary artery, and so we can see any blockages or narrowings, as you can see here. Once we find the blockage or narrowing, we do what's called a percutaneous coronary intervention. So that basically means that we use balloons and metal tubes to treat these narrowings. So here is a balloon that we inflate to compress the narrowing. And then we put a metal tube called a stent inside the coronary artery. And we can do these procedures for a number of reasons. So we can do these procedures in elective indications. So that means if a patient is having chest pains or angina, we can admit this patient, have a look at their coronary arteries and treat them. But we also do them in their emergency situations. So if a patient has a heart attack, we bring them into the laboratory 24 hours a day and do these procedures. So it sounds really great until you're up at 4 o'clock in the morning having to do this procedure. And it's not so great at that time, but it's worthwhile. And this is a picture of myself focusing very intensely on the picture. It was a staged procedure it was a staged photo for the university prospectus. I don't usually look this intense, but it was a good photo. opportunity. And this is my registrar, Dr. George. And as most great cookery programs, here's one I did earlier. So here you have the catheter injecting the dye, and you can see this narrowing here in the coronary vessel. And a couple of stents later, and you see a great result. And we do these procedures all the time. We do about 2,500 of these procedures every year at the Royal Stoke Hospital. So my interest is big data. That is to say, using routinely collected healthcare data for patients every time any of you goes to see your GP, anytime you have a hospital appointment or any sort of operation, you have an electronic healthcare record created. So my group uses these electronic healthcare records that are created from the whole of the UK to inform how we do procedures and to influence our practice. And this sort of research, although it's very fashionable at the moment, it isn't that new. I mean, you know, this is William Farr from 200 years ago, and he set up a system that routinely collected data, and he collected mortality data. So you could, for the first time, look at mortality rates of individuals of different ages, different professions, by marital status, and you'll be happy to hear that if you're married, your mortality rate is much lower. So it may not feel like that sometimes, but it is. And as I mentioned, you know, using this data offers unprecedented opportunities. It offers unprecedented opportunities to study real-world outcomes of patients. It allows us to look at the effectiveness of the sorts of treatments that we give patients. It allows us to capture complications of the treatments that we give patients. And it also allows us to develop models to predict what's going to happen to patients. And my work has focused on all of these 4 different arenas. So going back to PCI, as you can imagine, putting metal tubes into people's coronary arteries isn't a normal phenomenon. And so the body reacts by trying to develop blood clots. And if you get a blood clot forming inside these metal tubes, then that's really quite bad news. The patient will develop a heart attack and may even die. And so the way we stop these blood clots developing are by using different agents, different antiplatelet agents, different anticoagulants that stop these blood clots forming. But you can also imagine that if you give too much of these, then you have the other problem, a bleeding complication. And so it's a very delicate balance between inhibiting blood clots forming, but not giving too much medication to cause a bleed. And that balance is different for each individual patient, so it's very, very difficult sometimes. So over the past few decades in cardiology, we've been developing more and more potent drugs that inhibit these clots forming. And you can see that going from aspirin to clopidogrel to prasugrel is associated with a reduction in clotting events. But the problem is, on the flip side, there's quite a significant increase in bleeding complications. Now, for many years, bleeding complications were considered to be benign, just a bit of a hassle for the operator and for the patient. You just stay in a couple extra days. But they're not so benign. So we undertook an analysis with Xin Kwok, one of the people that's worked longest with me and is an ACF in my group, and I have no doubt will be giving an inaugural lecture of his own in the next 5 to 10 years. And we looked at over 500,000 patients, and what we found was that having the bleed is associated with a 3-fold increased risk of mortality. So having the bleed is not benign. It's associated with mortality. And there was quite a lot of editorials and press around this work. And it's not so straightforward because it's not just the bleed that has an impact on mortality. So some of the papers that we've published looking at bleeding events and outcomes. It's also how you treat the bleed. So for example, if you give a blood transfusion, that's also associated with increased risk of death independent of the bleed. So that's one of our other papers. Becoming anemic, again, is associated with an increased risk of mortality as well. So bleeding causes anemia, you might get a blood transfusion. All these things interact and increase your risk of mortality. So it's really quite important to try to minimize these bleeding complications during these procedures. So where do these bleeds come from? Well, these bleeds can come from a different number of sources. So they can come from the brain. You can have a hemorrhage in the brain, a stroke. You can have a stomach bleed, a retroperitoneal bleed. You can have skin bleeds, eye bleeds, bleeds around the heart. Or you can get a bleed around the access site. So historically, we used to do these procedures through the leg. And about half of all bleeds come from the access site, from the leg. And the reason why we used to do them through the leg was because the artery was much bigger, it was much easier. And the problem with this was that many people, after these procedures, about 1 in 10, used to develop these bleeding complications, which wasn't a good thing. And so people then in the Netherlands and Canada started to think, well, okay, why don't we try using another artery to do these procedures through the wrist? And the beauty of using the wrist is that you don't get these massive bleeding complications of the leg. And some people went over there to learn how to do these procedures from the Netherlands. And one of the very first people to do that was this character here, Jim Nolan, who gave his inaugural lecture a few months ago. And Jim went over to the Netherlands, learned how to do this technique through the wrist, and came back to the UK, where he set up a load of meetings, set up training, and people were coming to Stoke to learn how to do these techniques through the wrist, and has really helped change practice. And one of the areas that I started, and this is one of the reasons I became interested in this area. So one of my trainers during PCI was Doug Fraser, and he was Jim's trainee, so he was then my trainer. So Jim's almost like a grandfather to me, going from that side of things. And so Doug said, was the first person in Manchester Royal, my previous hospital, to start doing these procedures through the wrist. And Doug said to Jim, well, it would be good to invite Mamas to some of these meetings. So I started going to these meetings of Jim's and started developing more and more of an interest in the access site. And at the time, Jim was doing a fantastic job in getting people trained up to do all these procedures, but what was lacking was the evidence. So we could all say, well, going through the wrist reduces bleeding, but we had no evidence. We didn't have any proof that it was better for the patients. And that's where really my group has focused on over certainly the first part of my career. My group then used national data to show that going through the wrist is associated with better mortality outcomes. So people like Jim had changed practice, but there wasn't huge amounts of data, and my group then came in and provided a lot of that data. So one of the first pieces of work that we did several years ago was to look at whether bleeds in the leg were a bad thing. Because people used to say, well, okay, if you have a bleed in the brain, that's bad. If you have a stroke, it's bad. Whereas if you have a bleed in the leg, what difference does it make? It's just a bruise, who cares? And so we did this analysis in one of the top journal circulation interventions and showed that, yes, if you had a bleed in the brain, it was very bad. But if you had a bleed in the leg, it was also bad, and it increased your mortality by around 60%. So about 2011, there was a randomized controlled trial comparing PCI through the leg versus through the arm. And interestingly, it was a negative trial, so it didn't really show any benefit, apart from the very high-risk patients where there was a mortality benefit. And so at that time, I thought, well, okay, does changing access site practice reduce mortality in these really high-risk patients? So what we did was combine data from different trials in exactly these sorts of patients. So randomized trials from many years ago, usually from single centers apart from this last big trial. And we sort of combined data from 9 trials and 3,000 patients and showed that going through the wrist was associated with almost a halving of mortality. And this was really quite sensational because immediately I had phone calls from Nature Cardiology. So Nature phoned me to have a telephone interview saying this is really important work. And at the same time, there was an editorial from the Yale group, Alexandra Lansky in Yale, who was really critical of the work and said, well, okay, you've shown in this analysis, but it's only 3,000 patients, and it's from very specialist centres. It's very old data, some of the trials, and so we don't think it's relevant to everyday practice. So we would advocate just doing these procedures through the leg, and we think that your paper is using flawed data. So, we would say that you should just stick with current practice and that's it. And that sort of upset me slightly because it's the first time that someone's been so critical of the work. So at the time, Jim was on BSIS Council, and I spoke to Jim about this, and he said, well, the society have national data, and I can introduce you to the people that look after this data, and perhaps you can get hold of this data and we can have a look at this data. So I then approached Peter Ludman, who is the audit lead of our national society, and he put me in touch with these guys. So the National Institute of Cardiovascular Outcomes Research is an institute that houses data from all the national cardiac societies. So, for example, every time you have a heart attack, your data's collected. So every patient that has a heart attack in the UK, their data's collected and stored in NICOR. Similarly, every time you have a heart failure event, your data's collected and stored in NICOR. Every time you have a procedure or an operation, it's collected, stored in NICOR, and so forth. So my group has used data derived from here from a number of audits. So we've used data from cardiac surgery, interventions, heart failure, MINAP, TAVI, to look at patient outcomes and how we treat patients. So I'm just going to talk about this data here today. So what I did was speak to Peter. He put me in touch with NICOR. I applied for this data successfully, and we set about analysing. And I'm pleased to say that over the last few years, I've gone from being a research person, a research fellow at that stage, applying to NICOR for data, to being on their research executive, so one of only 5 people that's on the executive that decides and discusses research strategy nationally. So the BSIS dataset basically contains every PCI procedure undertaken in the United Kingdom over the past 10, 11 years. So it's close to 700,000-800,000 procedures. And it contains information about the characteristics of the patients, their demographics. It tells you about whether the patients survive, their complications, their outcomes, and so forth. And so this data set presents a real opportunity to look at how we practice cardiology, how we practice these procedures, and whether changing access site can influence outcomes. So this was the paper that we published in JACC Interventions, one of the top American interventional journals. And what we did was, over a 5-year period, look at every PCI undertaken in the United Kingdom, so close to 400,000 at that stage. And we just looked at the heart attack cases, so about 50,000 cases. And what we did was to look at access site practice, so whether going through the leg or through the arm made any difference. And you can see the blue is going through the leg and the red going through the arm. And you can see there was a great change in practice from 2006, where not really many people were doing it through the wrist, and I think largely through the efforts of Jim and his courses. By about 2010, it was about 50-50. We first looked at bleeding complications, and unsurprisingly, going through the wrist reduces your bleeding complications by about 60%. When you look at mortality, going through the wrist reduces your mortality by about 30%. And this was sensational. So at that stage, Carlo De Mario, who was the president of the European Interventional Society, gave an editorial to the work describing it as practice changing, saying that the message was very clear: switching to a wide-scale policy of radial offers a survival advantage. He was very firm in saying that operators should feel a mature obligation in learning these new techniques. And it was for the very first time that this sort of data was published from at the country level. People had published this from individual centres and perhaps regions, but no one had ever published this from the country. And I'm quite proud to say that in the UK we were the first to publish in primary PCI outcomes from a national perspective. And so a lot of interviews followed with that, very hard-reaching editorial as well. And since then, there have been a number of randomized controlled trials that have all shown a mortality benefit in these patients. Now, we do PCI for a number of reasons. You can have it in the elective situation where the bleeding risk is quite low, or you can have it in the emergency heart attack situation, which is what I've been discussing. So the evidence that I showed you applies to the emergency heart attack situation, but only a small proportion of patients will have PCI for that indication. So you can remember from the last slide, only 50,000 out of close to 400,000 patients had PCI for that reason. So one of the other things was, well, what happens to all these patients? Do they also have a benefit? Does the benefit relate to what your risk of bleeding is? Because you can imagine an intervention that reduces bleeding risk may have greatest benefit in those at highest risk of bleeding. So we looked at that in this paper. So what we did here was look at outcomes by axis site, blue radial, red femoral, in patients with different bleeding risks. These are the high-risk patients, these are low-risk patients. And across all bleeding risks, there's a mortality benefit going radially. But interestingly, the greatest mortality benefit is in those at greatest risk of bleeding. But can you guess where most people do their procedures? Here. So most people do their radial procedures here, where there isn't much of a benefit. Whereas in the patients where there's a huge mortality benefit, most people use the old-fashioned technique, femoral. So there's a great loss of opportunity there. And again, there was a big editorial at the time from the University of Laval and Sunil Rao from Duke as well, saying how important this work was. Again, we were interviewed in American websites. So here is an interview by me at that time at the University of Manchester, talking about how important this work is and how the benefit may relate to bleeding risk. This is from the website of the South American Interventional Society, where again it was highlighting the research. Again, further editorials and discussions. And so we're not really using this radial axis site in the patients that would get most benefit. And we've published a lot of papers around this with various colleagues in the room, so with Jim, with Doug Fraser, with Faz on some of the earlier work, showing that, you know, in elderly patients that have most to benefit, they're least likely to receive it. In females that have most to benefit, again, least likely to receive it. In patients that are very sick and have most to benefit, again, least likely to receive it. And it's not only the patients that have most to benefit that don't receive this practice, but also it's very different in different parts of the country. So this is a paper that we published earlier this year that I was first author in. The senior author was a chap from Manchester, Evan Bondobandelis. And you can see that red equates to high usage of radial and the white bits low usage of radial. And you can see over time, largely through a lot of the educational activities coming from Stoke, in fact, there's been a marked increase in utilization. But even in 2012, you know, you see large parts of London, the southeast coast, that are still using old practices. You can see Sheffield as well. And when we looked at what implications this change in practice had, we estimated that about 450 lives have been saved by this practice. But additionally, 260 lives have been lost by many centres not adopting this practice. And again, it was the first time anywhere in the literature that from a countrywide perspective, people had managed to quantify how many lives have been saved and how many lives have potentially been lost by not adopting this practice. And again, there was a huge amount of editorials, interviews with this paper. So this is from the American College of Cardiology, which was highlighting the work. This was another editorial in one of the other journals saying how important this work was. Now, the final bit of this part of the talk, and again, it shows the power of big data, is that you can really look at individual practice from big data. And what I was quite interested at the time is whether by doing more of these procedures, you get better at them. And if there's, you know, an amount of these sorts of procedures that you have to do, either from the operator perspective or from the centre perspective, where you get better outcomes. And what we found was that actually, from the centre perspective, it doesn't really matter how many procedures your centre does. The most important thing is the operator perspective. And it's not the number you do, but the proportion you do. So if only a small proportion of your cases are radial, you don't get a mortality benefit. It's only when you do about 30% or more do you get a mortality benefit. And the greater the proportion that you undertake, the greater your mortality benefit is. So before I did this work, I used to be about 80% proportion person. But going from 80% to closer to 90, 95%, there's a mortality benefit even greater. So that really pushed my practice to try to get to sort of 90, 95% practice. And there was a big editorial from the Harvard Medical School, this work saying that this was really important. It shows that people have to try their best to do as much of these procedures as possible radially, and this should become a quality metric for operators. And I'm very pleased to say that the British Interventional Society, largely on the basis of our work, has used this metric. And so if you look at any operator in the UK on the website, you will find what proportion of their cases they do radially. So I think we've had an impact there. So I've spoken about bleeding from the access site perspective, but there's lots of other causes of bleeding. So for example, the makeup of the patient, elderly patients are more likely to bleed than young patients, females more so than males, and so forth. The reason why we're doing these procedures, so in heart attack cases, they're much more likely to bleed than in patients coming in electively. The types of drugs we use, the types of stents we use. And so one of the areas in the past year or so that I've been focusing on is, well, okay, how common is bleeding in the United Kingdom? And I'm sorry to say that we don't really have good data for that. As of a year ago, there was no data on how common this complication of PCI was, even though it's probably one of the most important complications you can get of PCI. We have data from randomized controlled trials, but these are often very healthy patients. They're not the sort of patients that we deal with at everyday practice. And also, many of these randomized controlled trials are undertaken in the United States, where their practice is very different to the UK practice. So how do we know that this data is relevant to the United Kingdom? And so there was no real data on how common bleeding was. So we've been looking at, sorry, this is going the wrong way. So we've been looking at how common this is. And what we found is that bleeding rates have declined over time. And the main cause of the decline has been changes in access site practice and safer drug use. But offsetting that has been that we're doing PCIs on higher risk patients. So I think now with our work that we've been undertaking, we've got a fairly good idea of what's been happening to bleeding rates over time in the United Kingdom. They're decreasing. But we're only capturing what's happening when the patient's in the hospital, and that may be for 1 or 5 days. What we don't know is what happens for the next 20 years once we've discharged them from the hospital. And there is no good data nationally after a heart attack what proportion of patients in primary care develop bleeds. And this is one of the areas that we're going to focus in. So we were very fortunate in being awarded a grant from the North Staffordshire Medical Institute of £250,000 to look at that with Professor Kelvin Jordan from primary care and Professor Umesh Kadam. And what we're going to look at is in patients discharged, how often do the patients get bleeding events? Where do they get them? When do they get them? Is it just after discharge? Is it a year later, 2 years later? Are these bleeds important? What sort of patients get these bleeds? So I've talked about bleeding. I want to now talk about other complications. So my work is also focused around capturing other rare complications of these procedures. And one of these rare complications are strokes. Now, we all know what a stroke is, and it's, can completely change someone's life. I mean, having a stroke during these procedures, you may end up dying, or may make someone that's very healthy to becoming very dependent, completely impaired. So it completely changes people's lives. And strokes can be of 2 types, bleeding strokes or blood clot strokes. But the problem is, again, in the literature, very little data about how common these complications are. Very little data about whether they're increasing, decreasing. We don't even know whether the strokes are ischemic or hemorrhagic. Until our work, there was no published literature on what types of strokes happen in these patients. And the problem is, because they're so rare, about 3 in every 1,000 cases, they're very difficult to study. So if you try to look at randomized controlled trials where they may recruit 1,000, 2,000 patients, you'll only have 3 or 6 stroke events. You can't really tell from that, anything about the types of patients that get them, whether they're increasing, decreasing, and so forth. And so we've used the BSIS data set to look at stroke rates over time and what has driven these. And this was an analysis of 500,000 patients undergoing PCI, so every PCI undertaken in the United Kingdom between 2007 and 2012. And what we showed was that the clot strokes, ischemic strokes, have increased over time. And the reason why they've increased over time is because we're doing cases in much more acute patients, much more sick patients. Whereas the bleeding complications, the hemorrhagic strokes, have decreased over time. And the reason for that is that we're using much safer pharmacological practices. We've also identified the sorts of patients at risk for developing strokes. And we're currently working with collaborators in the United States to develop an international stroke risk score where patients will come in and you can give them and calculate the risk of developing a stroke. And there was an editorial at the time by Stefan James from Sweden, again highlighting the importance of the work, saying that these real-world data, this registry data is really important because it can capture these really rare complications and give you insights that perhaps can't be captured from randomized controlled trials in any meaningful way. And that work such as ours is important in creating scientific evidence and informing guidelines for PCI. Another complication that we did, or not we did, I haven't done it, but that we looked at was coronary perforation. So this is just a slide I got from the internet, and this is a coronary artery, the narrowing. When the operator tried to pass a stent here, the vessel ruptured and caused a bleed. And that can be fatal. It's a really serious complication. But again, very rare complication, except for some of the operators that I've worked with. And the problem is that, again, there's very little data about this complication. So when I was in Manchester with Faz and Doug and some of the other guys, we published our heart centre experience. And at the time, it's one of the biggest publications of 20 cases. But again, 20 cases over 15 years at the Heart Centre in Manchester is not going to inform you about how these complications occur, whether they're increasing, decreasing, the types of patients they happen in. So again, we've published this in Circulation Intervention with colleagues from Cardiff, Manchester, Birmingham, Middlesbrough. And we showed in this paper that this complication, if anything, is increasing over time. And the reason it's increasing is because we're taking on much more challenging coronary anatomy, much more elderly patients. We're being much more aggressive in treating this. And we also found that getting this complication was bad news. And again, a lot of editorials around this work. So the final part of my talk is around risk. So obviously, when we do these procedures, we always like to talk to patients about the potential benefits of these procedures. But there's always a risk, the flip side. Okay? And I think as a doctor, we're obliged to present very frank information to patients. Because on the one hand, we're saying to you, yes, this is going to be great for you, you're going to feel a lot better. But on the other hand, we have to be able to let you know what your risk is from going these procedures. But the problem is that there may not necessarily be ways of being able to calculate this risk. So I can tell you from a population level what the risk is, but then that's very difficult to give it at an individual patient level. And that's why we need to develop statistical models that enable us to calculate risk at the individual patient level. But the other reason for doing these risk scores is to look at how well we're performing. I think as doctors, we have a duty to be transparent about our outcomes. We do these procedures on people. We need to have ways of judging how good we are. Are we doing these procedures appropriately? Are our outcomes appropriate for the types of patients that we do these procedures in? Or are we doing these procedures not very well and having lots of complications, and then it becomes an issue of patient safety or retraining the clinician. And one of the areas that I got involved in quite late on, actually, was in the BSIS model. So we were using a very old risk model for PCI procedures, which wasn't really working terribly well and was completely underestimating risk. So I was involved in updating this on behalf of our national society, and we published this earlier this year. So now when we're talking to patients, we use this risk score that we can tell patients their risk. Now in the UK, procedures are very transparent. So if you go onto the website and look for me here, you will find my name on the BSIS website, and you will see how many patients I've undertaken procedures on over the past couple of years. Whoops, what's gone on there? Didn't save. And you will also find how I perform. So you will also find that, let me just go to the website. Sorry. They say never work with animals and children. I think computers also is a no-no, especially for these things. I always tell my colleagues to buy Apple Mac computers, not PCs, but the Apple Macs let me down. So anyway. So nearly there. So it almost feels like Back to the Future. Yeah, nearly there. Yes, there we are. So in the UK, there's a transparency agenda, so whereby you can look any operator up, such as myself, and you can look at our complication rate and mortality rate. So you can see that in my case mix, I'm the black dot, and this is where my dot should lie. So if it's going in this direction, then that means bad news. You know, I'm not performing as I ought to. And clearly it's on this side, so that means I'm performing rather well. And in terms of mortality, my actual reported mortality, again, is within the green box. So again, it shows that my rates are appropriate. So one of the difficulties, one of the shortcomings of developing models is if you end up as being one of the dots over here, you're not performing terribly well. I can't blame it on the bad model, and I can't say, well, it's nothing to do with me, it's just the poor model, because I helped develop it, so I can't use that excuse. But what happens if you have a new type of procedure where there isn't data to develop a new model? And we were in this sort of situation at this moment in time in the United Kingdom. So this is a heart valve, an aortic valve, and as we get older, this develops chalk, it calcifies. And so the opening of the valve becomes more and more restrictive. And if you leave the valve, then once you get symptoms, the median survival is about 2 years. So that's worse than most cancers. Okay, so it's a really serious condition. So the way that you treat this is with open heart surgery and by replacing the valve. But the problem is that most patients that get this sort of problem are elderly patients. And so you can imagine that elderly patients are quite high risk. And so a significant proportion of these patients, they're too high risk to undergo these procedures. And so then they're just treated with medications, and the mortality rate is absolutely huge. So more recently, there's been a new development called a TAVI, which is basically a bit like a big stent with a valve in the middle of it. And what we do is pass this valve over a balloon into where the normal heart valve is and deploy it. And we can use this procedure in patients that are really high risk from surgery. So they're too high risk to have their chest open, so they have this procedure instead. And this has completely revolutionized the way that we treat these patients, and this is the TAVI that's been successfully deployed. But the problem is, how do we predict risk in these patients? Because it's a new procedure. So you don't have tens of thousands of data to be able to develop a model to predict risk. So the way that we've been doing it in the past is by saying, okay, why don't we just use existing risk scores developed by the cardiac surgeons for operations where we split the chest open and put either a metal or a tissue valve in. And so what we did was then recently go to this national data, both that's on behalf of the British Interventional Society and the Society of Cardiothoracic Surgeons, to look at whether doing this is appropriate. And this is what we found. This is a paper that's just been accepted by the American Heart Journal. This is the actual mortality from these procedures, dark black line, and this is the mortality predicted by the various risk scores that we use. And so you can see that none of them are all that good in predicting mortality. And actually, if you just use the surgical risk models, then it's like flipping a coin. The surgical risk models are slightly better than flipping a coin in terms of predicting outcomes for the individual patient. So that's not good. So what other people have done in Germany, the US, in France, is develop their own TAVI risk scores. So then we looked at the utility of these TAVI risk scores, and they're not much better. So what we've been tasked to do nationally is to develop a national TAVI risk score for the United Kingdom so that we can then tell patients their individual risks from undergoing these procedures, but also benchmark ourselves and centres about how well we're doing these sorts of procedures. And the other thing about these risk scores, the existing ones, is that they don't agree with each other. So if you are defined as being low risk by, say, the German score, half of those patients defined as being low risk by the German score aren't low risk if you define them by the American score or the French score, and so forth. So you may be, on the one hand, defined as being low risk if you calculate your risk with the French score, but high risk by the German score or intermediate risk by the American score. What score do you use? Who knows? So we've been doing a lot of work looking at the best way of developing scores, whether we adjust existing scores, whether we combine existing scores, or whether we start again, and we're starting again. So what of the future? This is my son Andreas. I asked my son, what did you want to be when you grew up? What do you think of the future, Andreas? And he said to me, Daddy, when you and I grow up, notice he still thinks that I'm a child, when you and I grow up, I want to be a pirate. We can be pirates together. So there you go. The future, according to my 5-year-old, is that we're going to be pirates. I'm not sure how that's going to do for Ref. Perhaps, I don't know, in impact it might be useful. But seriously, in terms of future, a lot of our work has been in the bubble of what happens in the hospital, and the patients will only be there for a couple of days. But actually, most of the action is what happens to the patients when they've been discharged from the hospital in primary care, because they'll spend 1 or 5 days here and probably 20, 30 years over here. What determines, what their outcomes, their complications, what determines whether they go back into hospital? And so I'm collaborating now quite significantly with a lot of colleagues from primary care, people like Richard Riley, people like Kelvin Jordan, George, Pete, and various other colleagues as well in primary care to look at cardiovascular disease burden in primary care, where most of the action is happening. So I think in conclusion, routinely collecting data is important. It provides insights into efficacy and outcomes of patients with cardiovascular disease. It captures the types of practice that we do, the complications, outcomes. And this is really important because this sort of work isn't possible from randomized controlled trials. Everybody thinks that randomized trials are the panacea, but they're not. This sort of work cannot be undertaken in randomized trials. Obviously, in life, there are those that talk about things and those that do things, and I'm up here talking, so obviously someone must have done something. So I'd like to thank people past and present in my career that have worked, the statistical team that have contributed to much of this work, the clinical research group, many of which are here, so Xin Kwok as well, particularly, who's unable to be here, he's on call, but he's been in the group for the longest and he has done some incredible work. People like Jim Nolan, who has been absolutely incredible, how much he's helped me coming here. People like my mentor Ludwig in Manchester, Peter Ludman and Mark de Belder from BSIS, who have really supported the work that we do. Without those guys, I don't think any of this work would have been possible. Other people that I've worked with in my career, my colleagues at Manchester that really started me in the interest, trained me, and I'm very happy that they've been able to join me today. I'd like to thank the Heart Centre at Stoke, who have really welcomed me and really supported me in trying to build research. Absolute joy working in Stoke. And my colleagues at Manchester Royal as well, the Manchester Heart Centre. I spent, how long, 9 years, 10 years with these guys, really supported me, helped me incredibly. I'd like to thank ISTM and Primary Care as well for supporting me, collaborating with me, getting me involved in their work, and many of my colleagues are here. I also wanted to thank Andy from a personal perspective. As you know, that Andy will be leaving us, and I think it's incredibly big shoes to fill. Andy, you're going to be really sorely missed, and I'd like to personally thank you for helping me in this transition. I mean, your support has been invaluable, and sorry if I was a pain in the negotiations part. I'd like to thank our funders. So local funders have really supported our work. So the North Staff's Heart Committee, which has been run by Tony Berry, has raised over £5 million for patient heart care in the region. A huge amount of work, and I'm really pleased that Tony was able to join us this evening to see how some of the money that he has raised has contributed to this work. The North Staffordshire Medical Institute, that again has funded our work, and I think will provide important information about outcomes of bleeding from the primary care perspective. Other funders that have supported our work, and my parents as well, who often used to have to hold 2-3 jobs at any one time to be able to support us. We never, as children, we grew up in Longsight. We weren't very well off always, and they really worked incredibly hard and supported me throughout my career. And finally, these two guys, these cheeky monkeys that make things worth doing. So thank you for everybody.